So there we go. We have 8 o'clock, and with that, we will commence tonight's edition of our Next Generation Editors Journal Club from ASJ. I'd like to thank everybody for taking the time to tune in on this Tuesday night for what will no doubt be another excellent installment in the ASJ Journal Club series. For those of you who don't know me, my name is Ryan Austin. I'm a plastic surgeon here in Toronto, Ontario, Canada. And I'm joined, I'm also the lead of the Next Generation Editors. I'm joined tonight by one of our Next Generation Editors, Dr. Mariam Saheb El-Zamani, who practices just down the road in Mississauga, Ontario. And she's going to be moderating the chat box tonight. So if you have any questions, if you have any discussion points you'd like to bring, please make sure that you go over to the chat box, type in your questions. We'll be following it actively throughout the night and make sure to stimulate any discussion, and we'll try and bring it up so that we have a great interactive session tonight with our experts. Because tonight, hot off the presses from the March issue of ASJ, we're going to be discussing one of the editor's choice articles titled Identifying Regional Viscoelastic Properties of the Superficial Muscular Aponeurotic System and its accompanying commentary articles. We're very fortunate to have two expert discussants here tonight with us, and I look forward to hearing their insights on this article. First up, we have Dr. Michael Lee, who's a senior author of tonight's study from Dallas, Texas. Dr. Lee completed residencies in both otolaryngology, head and neck surgery, as well as plastic surgery at the University of Texas Southwestern, where he's currently on faculty as an assistant professor in the Department of Plastic Surgery. Dr. Lee has worked extensively with the Aesthetic Surgery Journal and is currently a social media editor for ASJ, as well as contributing editor for the facial surgery section for ASJ Open Forum. Thank you so much, Dr. Lee, for coming out to discuss your study and your publication tonight. We also are fortunate to have Dr. James Stuzin with us tonight from Miami, Florida, to discuss his commentary on tonight's article, as well as to share some of his experience and expertise in the field of facelift and facial surgery. Dr. Stewson completed his residency in general surgery at the University of Washington before completing his training in plastic surgery at the New York University Hospitals. Following his training in plastic surgery, Dr. Stuzin studied craniofacial surgery and facial reconstruction at the University of Miami Hospitals, as well as at UCLA Medical Center. Dr. Stuzin is an associate professor at the University of Miami School of Medicine and is well known to everybody as the co-host of the Baker Gordon Educational Symposium. So it's an honor and a pleasure to have Dr. Stuzin with us here tonight to share his expertise and insights into this article. So without any further ado, I will hand the reins over to Dr. Lee for his presentation. And thank you so much again for joining. Make sure you fire your comments and questions into the chat box.
Thank you, Ryan. Okay, so let's see. Okay, can you see that screen sharing? Good. So this is a paper that I wrote with Rob Lukavsky and off data that Andy Trussler and our department had gathered under the sort of tutelage of guidance of Dr. Fritz Barton, and I was happy to be to contribute and sort of manage this paper, identifying regional viscoelastic properties of the SMAS. We had no disclosures, simply for the progress of facelift surgery. We sought to do it. A little bit of background, as many of you know, that suspension of the SMAS is, especially today, believed to be necessary for at least good facelift surgery. There's a lot of different techniques that have been described throughout the decades, but all techniques rely on SMAS, at least modern day facelifts rely on SMAS, and inherently the viscoelastic properties of that tissue. So the aim of our study was to determine these properties and specifically the bursting strength, stress relaxation, and creep in different regions of the SMAS. So to do this, we looked at 12 cadaveric hemifaces, and then we divided the SMAS into lateral SMAS, which is that SMAS that's what we consider fixed mass over the parotid. We compared it to the middle cheek SMAS, which was over the masseteric space. And then essentially everything anterior to that and to the lateral canthus we deemed as more medial SMAS, and sought to see if there are different characteristics between those regions. Here's a figure from the paper showing you the lateral mid-cheek and the medial. And the superior aspect of the dissection was the zygomatic arch, and then the inferior was the inferior aspect of the mandible. So these are what the specimens harvested looked like, same size from each segment. And then this is the tensiometer that we used, an instrument which many of you probably know, but allows us to study these different properties. And you place the tissue into the instrument, and then you can measure them. So first up, we were looking at bursting strength, and based off of previous studies, we had an idea of where that would be force mass. So it was a spectrum we looked at between 5 and 30 newtons. The tissue is then pulled at a rate of 2.54 centimeters per minute, and we measure the force that's required to burst or to break the tissue. Then we look at stress relaxation. This is where you're measuring tension over time with a constant distance. So the tissue is held at 5 millimeters in extension for 1 minute, and we were able to measure stress relaxation. Then next, we looked at creep, and with creep, we're looking at the distance measured over time, so the tension is held constant, and we did that at 10 newtons. So our results were that bursting strength statistically was significantly, the threshold was higher in lateral SMAS. It took almost 40 newtons to burst the lateral SMAS. In the mid-cheek, 26.7 newtons, which was statistically less than lateral SMAS, but still more than medial SMAS, of which it only took 11.9 newtons. And then here is the bursting strength just played out. You can see our p-value. In terms of stress relaxation, regardless of the area, they were all very similar, which was interesting, but we plotted them out here, and you can see no statistical difference between the three groups. And then in terms of creep, which is the distance over time, lateral SMAS and mid-cheek had a trend of less creep compared with the medial SMAS. And here's that graphed it out. So from this basic science study, we were able to conclude that the lateral SMAS had a stronger bursting strength than that of the mid-cheek or the medial SMAS, that stress relaxation was similar across the board, and that creep trended to be lower in lateral and mid-cheek SMAS. In terms of discussion and where I think that this helps us in facelift surgery, there's a lot of different techniques to facelifts. None have ever proven superior to others. And, you know, that's every surgeon uses their own technique and modifies it and grows that technique. And that's the way it should be. But most modern facelift techniques, if not all, rely on some sort of suspension of the SMAS as compared to skin only. And that's been this way for decades. There's previous studies showing the viscoelastic properties of SMAS being somewhat superior to that of skin. And most all techniques, if not all, rely on suture fixation. So whenever surgeons are planning, modifying, or developing techniques, knowing the sort of strength characteristics of the tissue that you're suspending is beneficial. And that was the purpose of the paper, to provide that to the literature.
That's great. Thank you so much for sharing us that overview of your study there, Dr. Lee. And with that, we'll hand it over to Dr. Stuzin for some of his thoughts on this article and also its translation into clinical practice.
Well, thank you very much. And Michael, congratulations. I thought it was really an excellent study, and I congratulate you for doing it. It's a follow-up to Fritz's original article, which I think he published in 2013 with Andy Trussler, where they looked at the viscoelastic properties of the lateral SMAS in not in the cadaver, but in a patient, and this then looked at it in the cadaver. If I'm going to discuss this, Mike, if you could put that cadaver slide on, I think it'd be very useful for the people to take a look at it. And I'll give you some comments regarding why I think what you mean. That's the slide. See, okay, so let's focus at this slide because this is the SMAS. Now, I think for the participants of this journal club, Mike made the point multiple times that a modern facelift involves utilizing the SMAS to create shape. And what the SMAS really does is it repositions facial fat from the anterior face back up into the lateral face, which is where your suture line is. And why this study is so important is it gives you an idea about fixation in terms of where you want to put your tension to control the repositioning of the fat so you don't get relapse. Now, if you look at the lateral area where Michael's study showed the highest bursting strength, the reason for that, at least anatomically, is that that is an area where you have a lot of ligaments. The lateral cheek, especially in the lateral compartment of the face, you have a lot of fascia because you have the parotid gland, you have the ligaments coming out of the parotid into the lateral cheek, and that extends from that red line where the zygomatic arch is all the way down the anterior border of the sternocleidomastoid. It's a very dense set of ligaments. And within that sheet of SMAS, you'll have platysma as well. So you can see why that area is thicker and is going to have better tensile strength. And that is important when you do fixation of the SMAS. Now, the middle part of the cheek, and this was the point I made in the discussion, you start to lose some of that bursting strength. But the upper part, cephalically, you're over the lateral zygomatic eminence, and that area tends to is where the malar pad is, and it tends to be pretty dense because you have osteocutaneous ligaments coming from the zygomatic eminence through that fat. So I have found that that's actually a very useful area to dissect, and it has a pretty good tensile strength. Not as good as the lateral SMAS, but better than it does distally. Okay, once you get off the zygomatic eminence, you don't have those ligaments, so the SMAS is not as thick. And then medially, what happens anatomically is the SMAS splits. So it invests the elevators of the upper lip. So you have SMAS on top of the zygomatic major, and you have SMAS on the backside. And because it splits, it starts to thin out and it loses some of the tensile strength. So I think that's the anatomic reason that you see the differences from medial to lateral that was shown in Michael's study. Now, the clinical significance of that is that your best area to control fixation is laterally. And then as you go more medial, you're going to lose some of that fixation. But then this is where different techniques adopt their technique to try to improve fixation. I talked about that in my discussion in terms of how I roll the SMAS and how I suture the SMAS to improve the fixation. Now, Michael does, I know, more like Fritz's operation, which is a high SMAS technique. And that is one of the advantages of a composite type of facelift in that you haven't separated the skin from the SMAS, and that may aid in your fixation. So the final point I'll make at the start of the discussion is there is a huge deal of variability from patient to patient in terms of viscoelastic properties of the SMAS. When you get into a younger patient, you usually have very good fascia. When you get into older patients, the SMAS is often thick but fatty. And your fixation is problematic in those type of patients. And then if you get in a redo facelift, the SMAS is very thin, in which case, again, your fixation is more problematic. So the quality of the tissue often determines the results of the procedure. So this is a soft tissue operation, and we are at the mercy of the soft tissue. And I think going forward, I hope we have methods to improve the viscoelastic property of the SMAS so we can better control this procedure and prevent relapse. So those are my initial comments. Thank you.
That's great. Thank you so much. Anybody who has any questions or comments, please make sure to put them into the chat box. I'll ask a quick question just in follow-up to what Dr. Stuzin just said. I mean, you know, outside of age, you know, in younger patients having thicker, better quality tissues and older patients generally having thinner, you know, less robust SMAS, do we have any other predictive tools that we can use to try and predict who's going to have good quality tissue or not before we get in there? And the follow-up is, if you have somebody who has less, a lesser quality tissue, do you alter your fixation technique, your suture type, your suture strength, permanent versus resorbable sutures, based on the quality of the tissue, or do you just accept the fact that the tissue is what the tissue is, and we're limited by that as a factor?
Are you addressing that to me?
Yeah, sure. That'd be great.
Okay, firstly, you can examine the face and you can get a pretty good idea about the quality of the mass just by the examination. Some faces are very loose. You can tell they're going to be fatty. They don't have a lot of ligaments. Other faces are very tight, and you can pull on them and they don't have a lot of movement, and you can get a feel that they're going to have a big parotid. The bigger the parotid, the more extensive that lateral SMAS is going to be in terms of its viscoelastic strength. But remember that lateral SMAS has viscoelastic properties because of the ligaments coming through the parotid, through the SMAS into the skin. So the bigger the parotid, the tighter the face, usually the more robust the SMAS. That would be one way to know. You get into an older patient's very loose, kind of fatty face, you're going to be dealing with a fatty SMAS. You get into a redo face, most likely you're going to be dealing with a thin SMAS, but sometimes there's a scar interface in the subcutaneous plane that helps you with fixation. So these are all things you try to make judgments intraoperatively. Now, in terms of fixation, the thing that I think that Mike's article really brought out that I have found true in the operation I do, which is a bilaminar SMAS procedure, is if you take the lateral dissection way low in the neck, you go down along the sternocleidomastoid, maybe 8 centimeters below the earlobe, and free it from the ligaments of the sternocleidomastoid. And once you're off the sternocleidomastoid, and it's in a Wheeler relationship between the platysma and the deep cervical fascia, you back cut the platysma low, you can really go vertical with the SMAS and move it 6 to 8 centimeters, and you can get a very strong fixation in that area because the lateral SMAS is so strong. And that will elevate all that tissue from the angle of the mandible forward up into your suture line, and that takes the tension off of your anterior closure. Then I roll the SMAS, which makes it thicker, and especially over the zygomatic eminence where you have osteocutaneous ligaments, that area is pretty good for fixation. And then those are the tricks I've learned, and that tends to produce a pretty stable result in most patients.
Great, thank you. And for
Dr. That slide to show you, it would be easier to explain it, but not tonight.
Perfect. And for Dr. Lee, so it was an excellent study. I really enjoyed reading it. When you see these bursting strengths, 38 newtons for the lateral SMAS, 26 and 11, what forces are the SMAS seeing? Right? What is the relative value of these numbers, and how does that compare to the bursting strength of our sutures that we're using, for example, post-operatively?
So that's a great question, Ryan. There are lower than that is the answer, but I think it's variable because these are so these numbers are higher than what we've measured in the lab before. With SMAS samples. The question would be, what's the clinical relevance of that? Because we know in a post-operative patient that it's not simply a small amount of force. It's going to be dependent on, the mimetic muscles, the pulling, patients touch their face, if they turn their head. There's a lot of other factors that come into play. So I think whereas that's a good question, I don't know that it's of absolute relevance in facelift surgery. I think and clearly that's a whole lecture in just of itself, but I think the take home is that you want to use probably the strongest parts of the SMAS so that you're optimizing the result in the patient. So just like Dr. Stuzin said, and there's actually a good study. The only other one similar to this that sort of mapped it out was, I believe it wasn't Harsham, it was Hugh and authors, and they mapped it out in horizontal thirds, right? And showed that the superior SMAS had better properties. So we know the superior, just like Dr. Stuzin just said, the superior portion is really strong. The lateral portion from our study is really strong. And so you don't know what kind of tissue. You can assess it just like Dr. Stuzin said and get a good idea, and those are all spot on. But sometimes, especially in secondaries, tertiaries, when you get in and the tissue is not that great, or it's just so lax, you can, sometimes you get so much excursion, but then it's hard to hold a suture. And sure, you put in additional sutures, and I use permanent in my facelift, but you try to do everything. You try to check every box to get the most ideal result, the most long-lasting result that you can for your patient. And so there is a little bit of the art and practice of medicine when you're in these cases. If you have a young patient with really hardy tissue, then you probably have to do less than in an older patient with less robust tissue. But yeah, it's the daily activities that patients carry out could alter that Newton that we measure in the lab.
That's great. And one other point before, we've got some poll questions coming up here, so feel free to answer, and we'll check base with Miriam and the chat box in a second. In regards to stress relaxation, that was the other factor. You know, all the values were kind of around 50%, 48%, 60%. Does that mean that we need to be over tightening by that amount to account for that on the table, knowing that it's going to have that relaxation? Or how do we take that number and bring it into clinical practice?
Well, so I think that the biggest point of interest regarding that finding was it sort of illuminates how little we really, I should say how little we understand, but there's still room to learn. So why would some properties be stronger in certain parts of this mass and then be equivalent across the board in terms of relaxation? And the only thing that some previous authors have pointed out in terms of histology is just more fat as we move medial, which fat likely won't create the same amount of suture hold, but it may be tied to that stress relaxation number that we see. Now, your question, do we pull it extra tight, assuming that it's going to relax? And I would say no, you never, if you pull it so tight that you're trying to counter stress relaxation, you could essentially exceed the threshold for bursting, and then you've just lost all. So I don't think that's the answer. You know, you can go back in the 90s and read about the slackening effect that was seen in facelift surgery back then. And even though we've made advances, we still have, I think, a ways to go. But back then, the surgeons would talk about, you know, waiting a year and going back and doing a touch-up procedure where you resuspend to sort of counter that slackening, which I perceive as stress relaxation. And I think inherently there's going to be some patients where they would benefit 6 to 12 months out from doing that. And occasionally I do it, but I don't think the answer is to pull them overly tight the first go around.
Dr. Stewson, do you have any additional thoughts before we go to the chat and our attendees?
Yeah, well, you know, again, Michael does more of a composite type of facelift. In an extended SMAS or bilaminal, I think there is a place for adding more sutures. It's not necessarily so much to tighten the SMAS, but as the SMAS comes up, I always look and see how it conforms to the underlying facial skeleton. And you'll see sometimes it'll outpouch. And I will typically add more sutures to my roll to try to bring it not only vertically to correct laxity, but more to make it conform internally. Because as the SMAS conforms to the underlying facial skeleton, you start to correct radial expansion. And, you know, we think aging is a lot of up to down, but a lot of it's from in to out. And this is especially true in the middle part of the cheek or submalar area. It tends to expand outward because of the forces of animation and along the jawline and jowl. So the purpose of suturing is not just to vertically elevate the SMAS, but also to internally reposition the superficial fascia. And that's where adding more sutures I find is helpful. So I don't really think about tight. I think about conformation. Just like when I'm doing my platysmoplasty, I want to see how it conforms to the floor of the mouth and thyroid cartilage. So it isn't about tightening the platysma, but rather creating shape through your suturing.
Fantastic, that's great. So Miriam, do you have, I've seen some chat activity there. Do you have any questions for our experts here tonight?
Absolutely. The chats are really firing up. And I think part of that is as we're getting the polls coming in, we're seeing that, you know, a lot of our participants aren't necessarily exclusively doing facelift surgery. Most of them are doing less than 5 cases per month. And so a lot of the questions are centered around that. I'll start right from the get-go. I have Dr. Manelli here who has a specific question related to the study itself. Dr. Lee, did you have a control for the bursting strength of to compare the medial SMAS to, such as the malar fat pad or the supraplatysmal subcutaneous fat? Like, did you have something comparable you compared the bursting strength to?
No, you know, the way this study was designed was to be because there are so many variables that come into play with the face. My preference is to separate things out to where we can specifically answer more basic questions. So you definitely have soft tissue interface throughout the area that could impact it, but we did not seek to gather control of adjacent tissue.
And then another question that I think, you know, we've addressed at several points throughout the discussion is, you know, in your study, it seems that the SMAS was portioned off into thirds and vertical segments. In a previous study, I think we alluded to that it was portioned off in horizontal segments. Now, from your sort of background of the results, not what the ones that were published, did you see a difference in sort of looking at that cephalocaudal relationship of the SMAS tensile strength across your vertical thirds? For example, in that mid-cheek region, was there a difference between the superior to the inferior, or is it sort of a general sort of consensus we're coming to saying, taking the results of the 2 studies together, it sounds like, you know, going from inframedial to superolateral portions of the SMAS, you're getting increasingly more strength because of all the osteocutaneous and ligamentous connections we have.
Right. I think Dr. Stewson sort of alluded to this, that it is related to that sort of interwoven ligament structures, and that's why you even see it in as you get over to what we used to call McGregor's patch or the zygomatic ligaments. When you get to those structures, you see it, and you see that surgically. So these studies are typically the result of seeing something clinically for years. So when you're doing facelift surgery or even dissecting in the cadaver, you can see how as you get towards over the pre-masseteric space, how that's just more fibrous, or I'm sorry, more fatty, less fibrous, right? It's easy for surgeons to poke into the buccal space and take fat out that way because there's not much there, just a few spreads and you can retrieve that. So clinically, you see the superior aspect all the way over to the zygomatic ligaments, fibrous. You see, like Dr. Stuzin said better than I, that the platysma, especially inferiorly where there's the platysma cutaneous ligaments, you see that fibrous nature. But generally, as you move down to the areas where you'd like to see movement, the nasolabial fold and the marionettes, it becomes more fatty. And the problem with that is that's where a lot of patients want to see movement. And the saying goes, the closer your point of traction is to your point of action, the more you're going to get. But in fact, as we start to place sutures in that area, we become more limited in the type of excursion and stability that we get as far as a repair.
Perfect. I'm actually going to invite Dr. Nahai to pose his question and comment. I believe he has a question for Dr. Stewson.
Dr. Nahai.
Jimmy, thank you for joining us. The 45th anniversary of the publication of Mitz and Peroni, we're still talking about what is the best way to do this. You and I may be the only ones who remember when that paper was published, July of '76 in PRS. The question I have for you, I've seen your videotapes, I've seen live surgery when you were using the Vicryl mesh. I've witnessed that you put a number of sutures in there, but to the best of my knowledge, you're no longer using the mesh. So tell us why you did and why you don't do it anymore.
Well, the reason I used it initially was exactly because of what Michael's talking about in this study, that the viscoelastic properties of the SMAS were so variable from patient to patient. I thought if I added mesh to the SMAS, I could control the fixation. The problem with that is that I quickly realized that as soon as you put your first few sutures in, all the area of the SMAS that you undermined to where it was released from the retaining ligaments, so it was mobile, came up in your first suture line where the mesh was. And then if I added more sutures, I was essentially plicating unreleased fascia, but in an area there was no ligaments, onto my mesh. And so I just stopped using it and I didn't see any difference in the results. So what the mesh taught me was you didn't need to use mesh to control viscoelastic properties. It's the way you sutured the SMAS and the thickness of the SMAS you raised. So I became more precise on trying to leave fat on the SMAS where I was going to raise it, where there are ligaments, to keep it thicker. That gave me better tensile strength. And then adding more sutures seemed to give me more control in terms of maintaining fat long term. So that was my learning curve. So that took me 10 years to figure that out, Fuad. I'm a slow learner.
I wish the rest of us were like you. Thank you.
All right. And I have one more question from the audience. Really wanting to know, based on the results of your study, how do you feel that they really factor into the decision between doing a mastectomy or a SMAS plication kind of approach?
So that's a great question, and we sort of evaded that with the paper, just so that because again, these are basic science findings. They can help, but these aren't clinical studies where you're actually able to conclude as far as techniques, because you don't have that data. So for me, I try to utilize the lateral SMAS the most. But I also try to, in the paper that Dr. Stuzin was referring to, previously published by Barton and Trussler, we know that more tension is on the postauricular incision or on the platysmal suspension compared with that of the face. So I use, I'm gonna have to X off this like hole here. So I use the superior lateral in a transposition flap rotated behind the ear to secure it to the mastoid. So I'm using, to my knowledge, regardless of the patient, I'm using the strongest portion of the SMAS fixated to the mastoid fascia as close as I can get to the mastoid fascia, which is the most tension on my facelift - neck lip procedure. So it does factor into what I do. However, when it comes to plications and mastectomies, it's a different operation, and there are advantages to that versus a SMAS flap, and I think that's been sort of borne out in presentations and even comparison studies in the past. So I think the advantage to plications and to mastectomies as opposed to extended SMAS flaps or composite flaps is that those surgeons maybe, and I say maybe, they may be trading longevity for getting closer to the area of concern, which would be the nasolabial fold and the marionettes. So, that's my sort of thought on it, but you have to always stop short of saying anything is proven, because nothing is proving in aging facial surgery except for anatomic studies.
Absolutely. One of the things that I think is interesting that came out of the polls is we asked about the kinds of sutures that our surgeons are using, and most use resorbable over permanent, and the least use barb. Now, how do you feel that a approach that uses, possibly quilting or barb sutures that has more of a progressive tension almost approach to it would factor into this in terms of the longevity and being able to maybe take advantage of the properties of across the entirety of this mass?
So first, just let me say, so I use a permanent suture, and the reason I use a permanent suture is based off of fascial repair studies. So if you look at the strongest, longest lasting resorbable sutures, those are PDS2 sutures. And if you're using a 3.0 or larger, then you can get 60% tensile strength at 6 weeks, which is when wounds are 80% healed, right? So anything less than that, from a purist standpoint, the suture is not going to be a tensile strength long enough to allow 80% greater wound healing. And so because of that, and because I think that using a 3 or a 2.0 PDS is just too large in my mind for, I feel like patients would be able to feel it and it would be bothersome to them. I choose to use the permanents and I haven't had a problem. As far as barb suture and progressive tension, because I do a composite flap, I don't have the skin stays attached to the SMAS. And so I'm relying on those viscoelastic properties of the SMAS to sort of translate to the skin. And so I'd have to defer to someone, maybe Dr. Stuzin, for bilaminar flaps, and if there's a role for that in those types of repairs.
So, I'm sorry, so what's the question?
Do you want to repeat it, Miriam?
Sure. We're asking about sort of the suture choice and whether the use of barb sutures within the SMAS sort of having a more of a progressive tension kind of approach, if there's any role for that or what your experience has been.
I use a combination of permanent and absorbable sutures. Absorbable more medially because, again, the SMAS, I'm not trying to do as much tension medially, and that's where the patients can feel it laterally because that's where I want to keep the tension. I use permanent sutures. Also, when you reoperate on these patients, and if you're fortunate enough to stay in practice long enough and do a good job, you will reoperate on your patients. Having those sutures in place often shows you where to go ahead and reincise the SMAS, and you just take the old sutures out, and it shows you the plane to, do a secondary subSMAS dissection. So.
Excellent. And before we close off, Dr. Hamori is with us, and she has a question, so I'd like to invite her to ask that directly.
Sorry, I had to unmute myself. Sorry. Oh, hi, Dr. Stewson. Hi, you guys. That was a great talk you've all given. I've read the paper, and I was wondering if the aspects of the more medial SMAS are slightly weaker, could that account for radial expansion?
Christine, I think that's an excellent question. And if you look at the forces of animation, every time we smile, animate, we're pushing our cheek out. And if you look where radial expansion tends to show itself in the middle-aged face, it's here and here. I'm deflated, so I don't have it. But you look at a round face, you'll see that the submalar area tends to come out and the jowl comes out. And these are areas that we push out as we animate. And I think your point is right, that area doesn't have ligaments. It's a mobile area. And because it's mobile, it's easier for the superficial fascia and the overlying skin to separate from the deep fascia. And that's what causes radial expansion. And that's the hardest problem to correct in a facelift because everything we're doing is going from down to up. But what a lot of times we need to do is go from out to in to create shape. And that's why I use the sutures to see how the SMAS is conforming to the underlying deep facial framework.
Yep, that makes sense.
Dr.
Thank you.
Stuzin, could I get your thoughts on that area you just described, which we're all familiar with, but what is that buccal fat that's lateralized? What's your opinion on that region?
Are you talking about radial expansion in general?
Right. Well,
No.
it's specific to this region, which is, you always see that, right?
Well, that's buccal fat, what you're
Yeah.
talking about, but a lot of times it's not. A lot of times it's subcutaneous fat as well. And you talked about dissecting the pre-masseteric space. That's an area that's easy to dissect because there's very little connection between the superficial and deep fascia in that area. You know, and that's why you can do it with your finger once you're past the masseteric ligaments. And that area then prolapses out. Now, whether the buccal fat shows itself as well, that would depend on the facial configuration and the volume of the buccal fat. Sometimes you see it there. Sometimes if the deep fascia over the buccal fat is weak, you'll see the buccal fat down where the jowl is. And it can look like jowl fat, but when you palpate it, it's spongy. It's a balloon. Yeah. And that's just buccal fat in an abnormal location.
Yeah.
So those are my observations.
Same here.
One quick question that I'll have to both of our discussants tonight. A hot topic right now is tranexamic acid that we're hearing a lot more about in all forms of surgery.
Yes.
Where are you using it? How are you using it? Topical, intravenous, both, injected? I'll pose it first to Dr. Lee and then to Dr. Stuzin.
Yeah, I remember reviewing probably 1.5 years, 2 years ago, a study out of Europe. It was basically a survey study on it. And so I slowly incorporated it into my practice. And I've been using it now for probably 1.5 years. And so initially I started with local anesthetic, 1 milligram per cc. And I thought it was beneficial. And then I first in rhinoplasty incorporated it IV. And so now both rhinoplasty and facelift, I have my anesthesia provider give 1 gram IV 10 to 20 minutes before I'm going to start surgery. And then it's also in my local anesthetic. So I think it's helpful. Seems to be.
Dr. Stuzin?
I use it a lot. I think it's been a huge advance in facelift surgery, and especially in when you have to do that subcutaneous undermining, that plane is usually very bloody, especially when you transit from compartments. The lateral compartment is bloody, and then as you transit from the middle to the anterior, the malar compartment, you come along all the perforators along the masseteric ligaments. It's a very bloody dissection. The way I use tranexamic acid, I've tried it intravenously. I'll do it in males. I don't think it works nearly as well as adding it to your local. And I started off timidly. I would put 0.5 cc to 50 cc's, and I went to 1 cc. Now I'm up to 3 cc's. 3 cc's per 50 cc's a local. And that's where I am right now. It definitely makes a difference. I've seen no sign of tissue injury. And then I have topical sponges as well. And I take 10 cc's of tranexamic acid and dilute it up to 30 cc's, and those are my sponges. So I use it more topically and in my injection. And I might even go up a little higher. If I have a thick face, very bloody, on a frail skin, sun damage, I know it's going to be dry, I would probably drop it down. But I have seen no deleterious effects subcutaneously, and I've done it now in at least 200 facelifts. So I know
that's great.
Okay.
No, that's fantastic. I think, certainly we're hearing more about it, and to hear your experience with it and Dr. Lee both positive. I think that certainly that appears to be the trend, and everybody does seem to be really incorporating it in and raving about the effects, with really, as you mentioned, Dr. Stuzin, almost no downside that we see.
And not only will you cut your operative time, but you'll cut your drainage down. It's very interesting to see the drainage of the neck goes way down, and they seem to adhere quicker. It's very interesting. It improves tissue adherence. You have less ecchymoses and a quicker recovery. So it's all positive.
That's great. Well, with that, we are at 8:45. I think that it was an excellent discussion tonight, great interaction. I'd like to thank everybody for tuning in tonight. I'd like to thank Dr. Lee, and Dr. Stuzin for coming out, for presenting their article, presenting the commentary, stimulating discussion, and taking another step towards educating all of us on the nuances and the finer points in facelift surgery. So thank you both. For everybody who's in attendance, if you do have any industry contacts who are interested in any webinars like these supporting these movements moving forward through the journal, please contact Jackie at surgery.org, JACKIE at surgery.org. And hopefully everybody will tune in next month when we have the Young Aesthetic Plastic Surgeons Journal Club chaired by Dr. Mark Albert. And I look forward to everybody tuning back in with us in 2 more months for our next NGE Journal Club. So thank you all again. I hope you have a great night, stay safe and healthy, and look forward to seeing you in a month on Tuesday for the YAPS Journal Club.
Thank you very much.
Thank you.
Good night, everybody.